Montelukast. I actually was one of the sites in the late 90s that participated in the 2 to 5 year old trial of Montelukast in children with asthma. Um, it had pretty good data on usefulness in some types of asthma, particularly exercise induced symptoms. But they wanted to see, was it going to be more effective in younger kids where you can't really do an exercise challenge to show they have exercise induced asthma. So I participated as one of the study sites. Subsequently, in the new millennium, studies came out that probably head-to-head comparisons, inhaled corticosteroids are a better treatment option than Montelukast. But I always thought that Montelukast had a role, particularly if one had to push the treatment envelope with inhaled corticosteroid dose. Now, there was a signal in post-marketing surveillance about possible behavioral side effects. And during my time at Mayo Clinic, which was 2005 to 2017, the FDA did issue a warning about possible increased risk of depression and suicidal ideation in adolescents on Montelukast. Now, how long ago? I'm guessing that was about 10 or 12 years ago, but that's just by memory. In addition to that official recognition, post-marketing surveillance studies also showed a relatively high, when I say high, around 5%, incidence of adverse behavioral effects in younger children, not so much depression, mood alteration, suicidal ideation, but just adverse behavioral outcomes. And, for some of them, particularly the 2s and the 3-year-olds, you think, well, they're just terrible 2s. They're not disciplined. They're whatever, plenty of reasons. But I think enough of a groundswell occurred that at least unofficially among asthma specialists, this became recognized. And in fact, I give a talk annually at a children's respiratory medicine conference in London, England. And one of the visiting speakers from Montreal, Canada, in fact, talked on this very subject, probably about 2018 or 2019, before the pandemic, because we were still meeting in person. This gradually came out about behavioral adverse effects, not only in adolescents, but even in younger children. It has not changed how much Montelukast I use in my patients, but I did start to say to parents 2 things. Head-to-head, inhaled steroids are probably better. And if you want to go with Montelukast, just be aware that, your child, it may alter your child's behavior. Now, the reality is, I already talked about systemic steroids and how they can make your child miserable. Inhaled corticosteroids, much less likely to do it, but large surveillance studies from Northern Europe, again, where they can monitor this more effectively, do show probably of the order of 2.5% to 3%, maybe even as high as 4% of children experience some behavioral adverse effects with inhaled corticosteroids too. So it's probably a combination of the age, something that the drug does, and in certain susceptible individuals, it becomes manifest. Is 5% for Montelukast any more than 3% for inhaled corticosteroid? I don't know the answer, probably not. But certainly when you look at, what's called a risk-benefit analysis, the benefits, in my opinion, of inhaled corticosteroids are superior to the benefits from Montelukast in treating asthma. So it shifts the risk-benefit ratio, again, in favor of inhaled steroids over Montelukast as first-line therapy. Better benefit, maybe slightly less risk of adverse behavioral effects. So, and it's really come out more recently about these behavioral side effects being not talked about or not reported in the original studies.